First, a word about definitions. By viable, I mean simply that it's a pregnancy that can potentially result in a live-born baby. Non-viable, on the other hand, is a pregnancy that cannot possibly result in a live-born baby. And there are two types of non-viable pregnancies. There's a failed intrauterine pregnancy, somewhat colloquially called a miscarriage, or an ectopic pregnancy. Neither of those can potentially lead to a live-born baby. So here are a couple of examples. These are two viable pregnancies. This is a 5-week gestational sac. It's too early yet to see the embryo or a yolk sac, but this can potentially lead to a live-born baby, so it's viable. Here's a 6-week pregnancy with a heartbeat in the uterus. It's viable. 12 millimeter crown-rump length without a heartbeat in the uterus, not viable. It cannot possibly go on to result in a live-born baby. And an ectopic pregnancy similarly. So what I'm going to be talking about here basically on diagnosis of non-viable pregnancy comes down to when can you tell a woman, when you do an ultrasound, when can you tell her, I'm really, really sorry, but your pregnancy is not going to make it. This is an area in which there has been a lot of confusion and a lot of medical errors. Confusion about things like should you use a crown-rump length of 5 or 7 millimeters without a heartbeat for pregnancy failure? What about the mean sac diameter? How big should it be? HCG discriminatory level, or should you even use an HCG discriminatory level? And things like gestational sac versus my least favorite word in the English language, if it's in the English language, pseudo-gestational sac, one that I think should be banished from use, as we'll see. So in terms of the confusion, this is a quote from an editorial in Ultrasound in Obstetrics and Gynecology a couple of years ago. Would it not be worrying if the criteria to pronounce death at any other stage of human life were as variable as those that exist currently in early pregnancy? Medical errors abound. I can tell you I personally know of many, many, many lawsuits that involve incorrect diagnosis and therefore inappropriate treatment for what was thought to be a non-viable pregnancy. This is from an article published in 2010 in the journal OBGYN saying that quoting, a rapidly increasing source of medical liability actions relates to the unintended treatment of an intrauterine pregnancy with methotrexate misdiagnosed as ectopic pregnancy. And yet another paper in 2011 suggested that this may be a serious public health issue. There's even a Facebook group called Misdiagnosed Ectopic Given Methotrexate. I took a look a couple of days ago and it has 137 members, and another online support group, same thing, had 235 members as of the last time I looked. It's a really, really serious problem. So because of the confusion and the problem and the errors that are made, the Society of Radiologists in Ultrasound put together a consensus conference on early first trimester sonography, guidelines for diagnosing miscarriage and excluding a viable intrauterine pregnancy. And that consensus conference was held in Baltimore about a year ago, October 2012. I was the moderator. We had radiologists, OBGYNs, and emergency medicine physicians. And the article, the write-up of that conference actually just appeared about 6 or 7 weeks ago in the New England Journal of Medicine called Diagnostic Criteria for Non-Viable Pregnancy Early in the First Trimester. A little bit more terminology before we get into the meat of things. Two important terms: intrauterine pregnancy of uncertain viability and pregnancy of unknown location, IPUV or PUL. So if you consider all the things that you might see when you do an early first trimester ultrasound, at one extreme you may see a definite intrauterine pregnancy. You see a little fluid collection in the uterus with a yolk sac or an embryo that might or might not have a heartbeat. But if it has a yolk sac or embryo, it's a definite intrauterine pregnancy. At the other end of the extreme, definite ectopic pregnancy where you see an adnexal mass with a yolk sac or an embryo. And then in between, you can have a probable intrauterine pregnancy. In fact, I'm going to talk a moderate amount about this one shortly. An intrauterine sac-like structure without a yolk sac or an embryo. And a probable ectopic is an adnexal mass without a yolk sac or embryo. And then finally, if you see nothing, the patient has a positive pregnancy test, but you see no adnexal mass, no intrauterine fluid collection, pregnancy of unknown location. So the two terms, again, intrauterine pregnancy of uncertain viability is when you see an intrauterine pregnancy with no heartbeat. You don't know if it's viable. And a pregnancy of unknown location is where the patient has a positive pregnancy test and you see nothing. So with an intrauterine pregnancy of uncertain viability, the differential is either a viable intrauterine pregnancy or a failed intrauterine pregnancy, a miscarriage. And with a pregnancy of unknown location, positive pregnancy test, you see no intrauterine pregnancy and see no ectopic. The differential is a viable intrauterine pregnancy, a failed intrauterine pregnancy, or an ectopic. Pretty simple. So we're going to be looking at excluding a viable intrauterine pregnancy. Now, one more thing that's very important, and this is something that we talked about right at the beginning of our consensus conference. Whenever you're making diagnoses in medicine, there's a possibility of false positives and false negatives. And you have to think about what the consequences of false positives and false negatives are. So a false positive diagnosis of non-viable pregnancy, in other words, you say this pregnancy is not viable, it will not make it to a live-born baby. But if it's a false positive, you say that, but really there is a chance that it'll make it. That's what it means to be a false positive. The consequence is horrendous. It's initiating treatment that can potentially damage a viable pregnancy, such as uterine evacuation or methotrexate. You say it's non-viable, uterine DNC is done, methotrexate is given, but it's really potentially viable. That's a horrible consequence. What about the consequences of a false negative? You should say this is a non-viable pregnancy, but you don't. You waffle or you make a mistake. It's false negative. Consequences aren't nearly as bad, especially we're talking about here, a hemodynamically stable patient. The consequences are delayed intervention for a failed intrauterine pregnancy or an ectopic. These days, delayed intervention for an ectopic by a few days really has little significance in almost all cases. So as we can see, the consequences of false positives are greatly outweigh those of false negatives. And therefore, at the beginning of our consensus conference, we noted this, and the consequence is that criteria for non-viability should be set to eliminate false positives. In other words, have a positive predictive value of 100% or a specificity of 100%. Those three things all say the same thing. Specificity is very important here. So I'm going to talk about three main things. Diagnosis of intrauterine pregnancy prior to visualization of a yolk sac or embryo. When is an intrauterine fluid collection a gestational sac if you don't see a yolk sac or embryo? Intrauterine pregnancy of uncertain viability. What criteria allow definitive diagnosis of failed pregnancy? And a pregnancy of unknown location. Main question I'll address here is, can a single HCG value, so-called discriminatory level, exclude a viable intrauterine pregnancy if you see nothing on ultrasound? So let's deal with the first one, diagnosis of intrauterine pregnancy prior to visualization of a yolk sac or embryo. So this kind of thing. Here we see a little fluid collection, rounded edges to it. It's kind of round, sometimes they're oval. You don't see yolk sac or an embryo. Should you call this an early intrauterine pregnancy, or is it just some fluid in there? Back around 30 years ago, two signs of an early intrauterine pregnancy prior to visualization of a yolk sac or embryo were defined, so-called double sac sign, where you see a double echogenic ring around at least part of the fluid. Here you can see a double ring around all of it, sometimes you see around part of it, or the intradecidual sign, where you see that the fluid collection is not in the cavity. Pregnancies are not in the uterine cavity, they're in the decidua, they're beside the cavity. So this was another sign published. These were published about 30 years ago using transabdominal ultrasound. I can tell you that they're basically obsolete now because many pregnancies now have no sign like this one. I don't see any double sac sign, intradecidual sign. I do know that a week later there was a heartbeat, not surprisingly. So many pregnancies have no sign now. But this is a potentially misleading finding, this nonspecific sac-like intrauterine fluid collection in early pregnancy. One with rounded edges, no embryo, no yolk sac, no double sac sign, no interdecidual sign. So what do you say when you see one of these? Well, here's an example of what not to say, and this is the kind of thing that I've seen many, many times lead to horrendous outcomes and lawsuits. Here's one of those little nonspecific fluid collections in early pregnancy. 5-week scan was done for pelvic pain. She had a positive pregnancy test, and it was read as, and I quote from the reading, a sac-like structure within the endometrium may represent very early intrauterine gestation versus a pseudogestational sac. Let me tell you, this is the world's most useless report. Patient was sent because the physician taking care of the patient, the OB, the emergency medicine physician, didn't know. They knew the patient had pelvic pain and a positive pregnancy test and didn't know whether there was an intrauterine pregnancy or an ectopic. And this report says there's an intrauterine pregnancy or ectopic. It provides zero information. Useless report. So as a result, or rightly or wrongly, because of this useless report, a methotrexate was given for a suspected ectopic pregnancy. Rescan a week later. Now there's a yolk sac and an embryo, no heartbeat, there's some miscarriage, but it's a week too late. The pregnancy was poisoned a week earlier with methotrexate that presumably caused or might have caused the miscarriage. We'll never know. It was a malpractice lawsuit. Many, many, many lawsuits like this because of misinterpretation of these little nonspecific fluid collections in early pregnancy. If you want to know whether these little fluid collections are intrauterine pregnancies or pseudogestational sacs, decidual cysts, whatever you want to call them, fluid in the uterus in a patient with ectopic pregnancy, the two key questions are, how often does an intrauterine gestational sac have one of these signs, double sac sign or interdecidual sign? And the second key question is, in a patient with ectopic pregnancy, how often is there intrauterine fluid and what does it look like? Well, we answered one of these questions by a paper published, Carol Benson and myself, in Journal of Ultrasound Medicine earlier this year, and the second question also in the Journal of Ultrasound Medicine this year. And very briefly, if you look at what intrauterine fluid looks like in patients with a positive HCG, a positive pregnancy test, with an intrauterine pregnancy, a gestational sac can have a double sac sign, an interdecidual sign, or often no sign. And in ectopic pregnancy, there's usually no fluid at all, but when there is fluid, it's usually just irregular, debris-filled. You would never mistake this for an intrauterine pregnancy, but occasionally it's a little cyst, what might be called a decidual cyst or also a pseudogestational sac. These are the two that can confuse one for the other or look the same. From our two studies, about half of intrauterine pregnancies have no sign, and about 3% of ectopics have a similar cystic appearance. So if we put these in graphic form, you can see that if these are of intrauterine pregnancies, about half of them have a nonspecific sac-like structure, and ectopic pregnancies, about 3% have a nonspecific sac-like structure. So you can already see, comparing these pie chart pieces, that many more of these nonspecific sac-like structures are actually intrauterine pregnancies. But if you factor in the prevalence of intrauterine pregnancy versus ectopic, about 2% are ectopic, the almost all nonspecific sac-like structures are intrauterine pregnancies. A teeny number of them are ectopic. So if we do a little math, the incidence of ectopics in all pregnancies is 2%. Half of early intrauterine pregnancies have this nonspecific sac-like fluid collection, and 3% of ectopics look the same. By doing a little math, an isolated sac-like fluid collection in the uterus in a woman with positive HCG has an over 99% chance of being a gestational sac, a less than 1% chance of being a pseudogestational sac. So when you see one of these, there's a 99% chance or greater that it's an intrauterine pregnancy. So don't say it's a gestational sac or a pseudogestational sac. That makes it sound like they're equal probability. It's overwhelmingly likely to be a gestational sac. So the correct interpretation is to say that there's an intrauterine fluid collection highly likely to represent a gestational sac. Ectopic is far less likely, and treatments that can damage an intrauterine embryo, such as methotrexate or DNC, should be avoided, at least until viable intrauterine pregnancy is definitively excluded. Let's move on now to intrauterine pregnancy of uncertain viability and what criteria allow a definitive diagnosis of failed pregnancy. There are three types of criteria: crown-rump length with no heartbeat, mean sac diameter with no embryo, or time criteria, absence of an embryo on a follow-up scan. Looking first at the crown-rump length, a heartbeat is usually seen as soon as the embryo is visible. Here's a 1.7 millimeter crown-rump length, and you can see a little heartbeat. You almost always, once you see the embryo, you almost always see a heartbeat. In fact, if I didn't see a heartbeat in this 1.7 millimeter embryo, I would tell the woman that the prognosis is very poor, but it's not absolute. So what we're looking for in diagnosing pregnancy failure is absolute. At what crown-rump length is a heartbeat always seen in a normal pregnancy? What's the cutoff value above which cardiac activity is consistently visible on transvaginal ultrasound in a normal pregnancy? The early studies found 4 to 5 millimeters as that cutoff. So 5 millimeters in the early 90s became the generally accepted cutoff. In other words, if you saw a crown-rump length of at least 5 millimeters transvaginally and saw no heartbeat, said definitive pregnancy failure. In the last few years, concerns arose. First of all, the study populations that set that 5 millimeter crown-rump length cutoff were actually very small study populations. And then over the last few years, several cases of embryos with crown-rump lengths of 5 to 6 millimeters and no cardiac activity have been reported to then turn out to be normal. And then yet other studies have shown that there are inter-observer variability. I may go in the room and measure something at 6 millimeters. Next person go in the room, same patient, same time, and measure 7 millimeters. So because of that, the SRU consensus panel that I talked about, and these numbers are in our New England Journal article, advocate use of 7 millimeters and no heartbeat as definitive for failed pregnancy. Anytime you see a crown-rump length, you see an embryo, if it's less than 7 millimeters and there's no heartbeat, it's very suspicious for failed pregnancy. If you see a 2 or 3 or 4 millimeter embryo, no heartbeat, it's suspicious, but you should follow it up. It's not definitive. Here's a couple of examples of definite pregnancy failure, 7 millimeters and 8 millimeters with no heartbeat on these video clips. And here are a couple that are suspicious for pregnancy failure, 4 millimeters and 5 millimeters with no heartbeat. Highly likely, very suspicious, but not quite definitive until it's 7 millimeters. Same thing with mean sac diameter. What's the cutoff value above which an embryo is consistently visible on transvaginal ultrasound in a normal pregnancy? The early pregnant studies suggested 16 or 17, and in the early 1990s, 16 millimeter with no embryo visible became the generally accepted cutoff. But similar studies and concerns arose, and because of those, our consensus panel advocates using a mean sac diameter of at least 25 millimeters and no embryo as definitive for pregnancy failure. Mean sac diameter of 16 to 24, the old cutoff of 16 up to the new one of 25, is suspicious. And here's an example of definite pregnancy failure, mean sac diameter of 28 millimeters with no embryo. There's a little yolk sac, but no embryo, definitive for pregnancy failure. This is 17 millimeters with no embryo, suspicious for pregnancy failure, requires follow-up. Not all pregnancies will ever get to a crown-rump length of 7 millimeters or a mean sac diameter of 25 millimeters, so there have to be other criteria to diagnose pregnancy failure, and those are time-based ones. So the two that we advocate as definitive for pregnancy failure are, if you do a scan at one point in time, you see a gestational sac with no yolk sac, a little gestational sac. If it's at least 2 weeks later and there's no embryo, that's definitive for pregnancy failure. And if you see a gestational sac on the initial scan with a yolk sac, so it's a little further along, if 11 days later there's no embryo, it's definitive for pregnancy failure. And there are some suspicious criteria that are a little less, including no embryo at least 6 weeks after last menstrual period. That's suspicious for pregnancy failure. And here's an example of a definite pregnancy failure based on time-based criteria. You see a little gestational sac. 15 days later, there's still no embryo. It meets this criteria for definite pregnancy failure. And this one meets one of the criteria for suspicious pregnancy failure. 6 weeks after LMP, you're still not seeing an embryo. Suspicious. Other criteria that are suspicious for pregnancy failure include an empty amnion, the amnion adjacent to the yolk sac with no embryo, or a large yolk sac, or a small gestational sac size, can be quantified or just eyeballed. Here is a yolk sac and amnion, but no embryo, so there's an empty amnion, suspicious for pregnancy failure. A large yolk sac is suspicious for pregnancy failure. And this is a small gestational sac size. The embryo looks crowded within it. If you want to do the numbers, the mean sac diameter minus crown-rump length is less than 5 millimeters. These are suspicious findings that should be followed closely. The final topic is in diagnosis of non-viable pregnancy that I'll talk about is in a pregnancy of unknown location, positive pregnancy tests, and you see nothing. Nothing in the uterus, nothing in the adnexa. Can a single HCG value, the discriminatory level, exclude a viable IUP? The discriminatory level is a concept that was originated in 1981 and defined as the HCG level at which a normal intrauterine pregnancy is consistently seen. With improvements in ultrasound technology, the reported discriminatory level has been consistently dropping. In the initial study in 1981, it was 6,500 milli-international units per ml. With improvements in technology, especially transvaginal ultrasound, we see pregnancies earlier, so the discriminatory level has dropped. In 1990 and beyond, with transvaginal ultrasound, it's been reported to be 1,000 to 2,000. The most conservative definition, if you're going to use one, at least, is 2,000. So the rationale is if you see an HCG above 2,000 and on ultrasound there is absolutely nothing in the uterus, then if the discriminatory level works, the patient can't have a viable intrauterine pregnancy. The differential diagnosis is either a failed intrauterine pregnancy or an ectopic, in other words, a non-viable pregnancy. So it would be safe to treat this patient with DNC, with methotrexate or DNC, if the discriminatory level works. And therefore, because of that, there are a couple of proposed management algorithms for when the HCG is above 2,000 and no intrauterine pregnancy is seen. One of the management algorithms says do a DNC and then treat for ectopic pregnancy if you see no chorionic villi. Another management algorithm says just go straight to methotrexate for presumed ectopic when the HCG is above the discriminatory level and you see no intrauterine pregnancy. Well, that's the theory, but the reality is more like this. Here's a woman. It's a decent scan. Not the world's greatest, but pretty good. HCG was over 4,000, more than double the discriminatory level. See nothing in the uterus. And a month later, there's a normal 9.5-week intrauterine pregnancy. The discriminatory level didn't work for her, and she went on to have a normal baby. Fortunately, in our institution for years, we haven't believed in it, so she didn't get treated. We published our results a couple of years ago. Over 10 years, we saw 9 patients whose HCG at initial ultrasound was over 2,000. We saw nothing and came back with a heartbeat on a follow-up ultrasound. Most of them went on to normal liveborns. Our consensus panel, and again, this is also in our New England Journal article, with respect to HCG and pregnancies of unknown location, conclusions are as follows. The HCG levels in viable intrauterine pregnancies, non-viable intrauterine pregnancies, and ectopic pregnancies have a lot of overlap. If the HCG is below 3,000, treatment for a possible ectopic pregnancy like methotrexate or DNC, followed by methotrexate, should not be undertaken to avoid the risk of interrupting a viable intrauterine pregnancy. But what if it's over 3,000 and you see nothing? Well, viable intrauterine pregnancy is possible, but it's highly unlikely at that point, but it is slightly possible. But there's another reason this patient who has an HCG above 3,000 and you see nothing in the uterus or adnexa, there's another reason that she shouldn't get methotrexate, and that's because her most likely diagnosis is not ectopic pregnancy, it's a failed intrauterine pregnancy, and you shouldn't be giving methotrexate for women with failed intrauterine pregnancies. She's giving methotrexate as a dangerous drug for nothing. In summary of everything that I've said, in a patient with a positive HCG and no adnexal mass, If ultrasound shows no intrauterine fluid collection, namely she has a PUL, don't intervene before getting a follow-up HCG and ultrasound. There may be a viable intrauterine pregnancy. Failed intrauterine pregnancy is more likely than ectopic. So don't intervene if in a PUL, pregnancy of unknown location, with a positive HCG. If a patient has a positive HCG and no adnexal mass, and the ultrasound shows an intrauterine fluid collection with rounded edges, it's likely an intrauterine pregnancy, as I showed earlier in the talk, so don't intervene. What about if ultrasound shows an intrauterine pregnancy and no cardiac activity, the intrauterine pregnancy of uncertain viability? Don't intervene unless the ultrasound findings meet strict criteria for failed pregnancy, including a crown-rump length of at least 7 millimeters and no heartbeat, mean sac diameter at least 25 millimeters, and no embryo, or some time-based criteria. Now you notice a pattern here. Don't intervene. Don't intervene. Don't intervene. First, do no harm to early pregnancies. Avoid intervention until you're absolutely sure the pregnancy is not viable. This is from an editorial written by myself and Carol Benson in Journal of Ultrasound Medicine a couple of years ago.